Now let's learn about the management of hypovolemic shock. First, airway support. First is airway support. Initial management of patient is to establish airway support. Second is fluid therapy. So which type of fluid is given? Fluid therapy. Here 0.9% NS IV fluid is preferred. Why RL is not preferred? Because why RL is not preferred? Because RL has citrate. RL has citrate component and that will cause chelation of freshly transfused blood. Hence, RL is avoided. Freshly transfused blood. Hence, it's avoided. It's avoided. Then, the definitive management of hypovolemic shock includes induction of massive transfusion blood protocol if needed. Third is massive transfusion blood protocol. Blood protocol if required. Or administration of whole blood after a cross match. Administration of whole blood after a cross match. Administration of whole blood after cross match. And things to avoid: colloids. Colloids should not be given for first 24 to 48 hours. Colloids should not be given. So colloids are to be avoided. Colloid to be avoided for first 24 to 48 hours. Why colloids are not given? To prevent intracellular hydration and third space accumulation. So colloids should not be administered in first 24 hours to 48 hours to prevent intracellular hydration and third space accumulation. Yes, and most important of this, always add a proton pump inhibitor to prevent sepsis, because gastric mucosa is very sensitive to prevent sepsis. So never forget to add proton pump inhibitor to hypovolemic shock, because gastric mucosa is the most sensitive in GI tract to hypovolemia, and that will lead to stress also. So to prevent all this, to prevent sepsis, to prevent stress ulcers, we have to administer PPI, that is proton pump inhibitor, like pantoprazole IV. So now is how to monitor outcomes of shock. So monitoring outcomes of shock. So the best parameter for this is first urine output. If urine output is 0.5 ml per kg per hour, that's good. is considered as good urine output. Second is emboss, that is mixed venous oxygen saturation. So what happens in this technique? This is heart, suppose this is right atria, this is right ventricle, this is left atria, and this is left ventricle. So here the central catheter is inserted and right. So what happens here? The catheter is inserted into the right atrium to measure the venous saturation, and this is very useful. It can be prognostic as well as diagnostic. And diagnostic. So how? I'll tell you. If emboss is increased and decreased. So emboss is increased in case of septic shock. And emboss is decreased in case of hypovolemic shock. Now, third, administer bolus, that is initial bolus of 250 to 500 cc of anise. Will categorize patient as responders, non-responders, and transient responders. Non-responders and transient responders. Transient responders. Responders are considered as a good sign, and we can further manage them conservatively and then post for any surgery later if needed. And non-responders need an urgent surgical intervention to be done. We are going to learn about massive transfusion protocol. It is massive blood transfusion protocol. So when we have to activate a massive transfusion protocol, in case of severe shock, we have to activate massive transfusion protocol. And how? By transfusing packed RBCs, plasma, and fresh frozen plasma, that is FFP, to the patient. And before initiating MTP, first make sure that administer tranexamic acid 1 gram IV stat. So point to be noted: before initiating massive transfusion protocol, that is MTP, administer tranexamic acid 1 gram IV stat. 1 gram IV stat. So now we'll see what is stage 1. In stage 1, give 4 units RBC plus 2 units of FFP stat and check for the response. Then in stage 2, stage 1 plus further 4 packed RBC plus 2 FFP, 2 units of FFP plus one single donor platelet to be repeated. Platelet to be repeated. Now the stage 3. At stage 3, for the step 2, that is for the this step, for the step 2 plus calcium to be given and plan for surgery. So this is all about massive transfusion protocol. Plan for surgery. I will see complications of massive transfusion protocol. So first we are transfusing blood in abundant amount, so there will be hypothermia, then there will be hyperkalemia. Why there will be hyperkalemia? Because the RBCs, they are stored for a long time, and the stored RBCs leads to leak of potassium from intracellular to extracellular, and that leads to hyperkalemia. Third is hypocalcemia. Because the stored RBCs they put citrate for preservation, and citrates binds with calcium, that leads to chelation, and that leads to hypocalcemia. Then fourth is that is transfusion associated acute lung injury. Transfusion associated acute lung injury. And fifth one is TRACO, that is transfusion associated cardiac circulatory overload. Transfusion associated circulatory overload. And there could be non-hemolytic reaction as well, febrile non-hemolytic reactions, because we are giving large amount of RBCs. So that's all about massive transfusion protocol.